Good afternoon. I am Brian Blaze, the founder and president of Paragon Health Institute. And thank you for joining us today for this event that I've been looking forward to for a couple weeks now. Insights from 12 years on MedPAC, the past, present, and future of Medicare reform. Medicare is our nation's largest and most influential federal health program. MedPAC was created by Congress to assess Medicare's efficiency, quality, and access, as well as to make policy recommendations. Today, we bring together two outstanding leaders who deeply understand Medicare and MedPAC. We're really appreciative of Mike Chernew joining us. Mike is the Leonard D. Schaefer Professor of Healthcare Policy at Harvard Medical School and one of the country's foremost healthcare economists. He served as chair of the Medicare Payment Advisory Commission from 2012 to 2025, helping shape recommendations on Medicare payment policy. A member of the National Academy of Medicine, Dr. Chernow's research focuses on Medicare, healthcare spending, insurance design, and value-based payment. And he has had a major influence on both academic scholarship and federal health policy. And he is joined by my colleague, Demetrios Kouzoukas. Demetrios leads Medicare, the Medicare Reform Initiative at Paragon, and he has been with Paragon since the organization began about 4.5 years ago. Demetrios is the former director of Medicare at the Centers for Medicare and Medicaid Services. He was in that capacity for the entire first term of President Trump. And while in that capacity, Demetrios oversaw important reforms to Medicare payment policy and a reduction in Medicare's improper payment rate. Michael and Demetrios will discuss the role of MedPAC, lessons from past Medicare reforms, the state of the Medicare program, opportunities for future reforms, and much more. Today's event is being recorded. The event video will be shared on our YouTube channel and on Paragon's website, which is www.paragoninstitute.org. We're going to bring up a QR code. If you're joining us and you don't get Paragon's weekly newsletter and you want to follow us on social media, please scan that QR code on your screen. And we'd love to keep you updated on future events as well as updates on Paragon research and policy developments. Now it is my pleasure to turn this event over to Demetrios. Gentlemen, I wish you a great conversation.
Thank you, Brian, and thank you, Mike, for joining us today. And thank you to our audience for listening in. This is something I've been looking forward to for a while as well. And really very glad to have the opportunity to talk to Mike because he's really been at a really unique and close up point in viewing and having a hand in Medicare policy over the last couple of decades, if not longer. And MedPAC is a unique institution. It's an entity that people in Washington, even those who are very wonky, don't always appreciate or understand exactly the impact or the way that it operates. And so today is an opportunity for us to dive in a bit with that, with Mike, and to understand the implications of some of the work that it's been doing and that he's been up to as well. Yeah. So Mike, tell us what did you enjoy most about your service on MedPAC?
Yeah. So first of all, Brian and Demetrios, thank you so much for having me. I'm thrilled to be here. I'm thrilled with your interest in MedPAC. Everyone's interested in Medicare. It's not clear how many people are interested in MedPAC, but it's really an honor to join you. And thanks for that great introduction. This is going to be, as we talked about, this is going to be more of a conversation than me just answering a bunch of questions. So please, Demetrios, interrupt me. But to answer your question, I'll say two things. The first one is I enjoyed the people. I think that's true of most things people do in life is you enjoy the people you're with. And I'll say two things about that. The commissioners were just wonderful. They're incredibly accomplished, bright people, insightful people. I spend a lot of time with academics, and no shade on academics, but it's nice to spend time with non-academics, particularly non-academics that are so accomplished. And then I want to shout out to the staff. I've had other situations where I've come in contact with folks in the sort of federal government, like, for example, at CBO or the Office of the Actuary or CMS, positions like you had. And I will say that one thing I take away from that, and I'll say, particularly with the MedPAC staff, is really how dedicated these people are. I think they have a lot of opportunities where they could do a lot of things, and they choose to spend their time working on Medicare policy. And I think it's very clear seeing MedPAC up close that these people are motivated with the idea of providing policymakers with the information they need to make good policy. And I think seeing that dedication is really heartening. The second thing that I enjoyed, of course, is just being able to engage in the policy set of discussions. Medicare is an incredibly complex program, and as being on MedPAC, you learn a ton about it you wouldn't otherwise learn, and you learn a lot about the puts and takes where the policy trade-offs are, and just the intellectual opportunity to do that, for me, I found quite enjoyable.
I agree and understand the sentiment as well in terms of my time in the policy area and in the government as well, and just the ability to rely on experts who have been so deep and part of the institutional memory sort of at your fingertips too is also incredible. And I'm sure you're withdrawing from that now too. Are there policies in particular that you think MedPAC had a biggest impact on during your tenure?
So, as you know, it takes a long time to go from like recommendations to policy and stuff. So I'll mention a few areas, but understand that there's a long runway till you actually see policy take off. But certainly we did a lot of site neutral work. Now, there'd been a lot of site neutral work before. I think the site neutral work we did emphasized both expanding the set of providers that might come under some site neutral policy, and there's some grandfathering issues that are kind of wonky in the existing site neutral rules, and I think there remains a current active discussion around site neutral. I think alternative payment models, ACOs in particular, our recommendations have been influential in the discussion. I don't want to take credit for sort of the direction that CMS has gone in, but I do think there's certain things like trying to make sure that the models are streamlined and work together. They deal with the ratchet effects that are minimum consistent with where MedPAC was. And I guess the big one that if you just were to judge by the volume of my inbox is Medicare Advantage. So there's, again, a lot of things going on in Medicare Advantage, much of it consistent with MedPAC recommendations. A lot of the stuff that MedPAC has recommended haven't fully worked through the Medicare Advantage policy process. We can have a specific conversation about that, but I certainly think we've been an important voice in the Medicare Advantage debate. And there's a bunch of others, for example, physician payment, and we could have discussions there that I think are probably
So thinking about those topics and others, people in Washington always say that if you want to make an impact on policy, you need to have data and you need to have analysis. And that maybe is a given, but I'm interested in your views on when is data and policy either not enough or unnecessary? You know, sort of these other cases. When do you see that Medicare has made policy changes that aren't necessarily based on data, or when the data wasn't enough?
Well, so first, I agree, and I'll say that MedPAC at its core is an analytic agency. It provides analytic support to Congress and other times, like its advice sometimes goes to CMS. But I think at its core, MedPAC is an analytic organization. And what I would say in terms of when data is not enough, a lot of the decisions, a lot of the trade-offs are decisions that are sort of value-based. Data can't tell you much about the values. It doesn't tell you what your objectives are, doesn't tell you how to make trade-offs. It just tries to illuminate what those trade-offs are or identify where the problem areas are, for example. So you need data to understand what's going on, for example, with physician access or hospital access, or you need data to understand what's happening to Medicare Advantage payment. But that doesn't tell you how you should respond. How you respond has to do with the various trade-offs that you face in a bunch of ways. So I think data is informative, but it doesn't in and of itself drive exactly what the policy should be. In terms of when data is unnecessary, that's harder. I think there's almost always a role for data in most policy, but I think there are times where policymakers may be driven by some philosophical view, and in which case they care less about the data. My personal view is that you should always think through what the puts and takes are in terms of the trade-offs for any policy you want to do, and data can almost always be informative in doing that. So I'd have to give a lot deeper thought as to where you could do policy with actually no reliance on data.
I had the good fortune to work with Paul Mango, and he had spent a lifetime at a career at McKinsey, and then came to CMS, and he observed that he thought it was the most data-free environment he'd ever worked in, which was not quite. You know, we work with a lot of data, but his critique was that that the time cycles that by which time that Medicare understands what's been happening. We roll out a new rule. It takes time to implement. There's an impact. It's measured years later. And so the decisions that are made, you just don't have the precedent to understand exactly what's going to happen and understand what's happening in real time because of the time lags.
Yeah. So, I mean, I agree. Although, again, the data you use, and even the MedPAC data, we're making recommendations for payments going forward using data from the past. There's always some extrapolation of data, some extrapolation of how you think markets work, and I think oftentimes supplemented with some theoretical sense of how markets work and how providers will respond. You're never going to have a perfect assessment of what will exactly happen if you were to do X, Y, or Z. So in that sense, you're always lacking that data. And I think one of the things that's going on now, I think, is CMS has a big initiative to get more data quicker. And I think that's quite valuable. But I think past data can be informative for future policy. And so certainly you see this in almost all CMS areas, but just my take.
That's a great, I think, opportunity to talk next a little bit about how MedPAC does its work. Because I think at the bottom, what I hear you saying is that that data ultimately involves methodology and judgment calls. And the Congress and the agencies and the policy community rely a great deal on the MedPAC data and MedPAC analysis. So maybe we can talk a little bit about exactly how MedPAC does that and how it goes about it. First of all, does MedPAC have access to unique data for its work?
Sure. In a bunch of different ways, without going through all the data that they use, and of course the data changes. So they collect their own data for things like physician access and some of the update stuff. They do focus groups. So MedPAC generates data, often done through contractors in support with running focus groups or doing surveys. So they have that data. And there's certain types of data, say some of the Part D rebate data, for example, that MedPAC has access to that aren't publicly available. Even some of the other data that MedPAC uses, like the Medicare Advantage encounter data, that's publicly available with a data use agreement, but it's not like you could go on the web and download all of that data. I'm not sure what unique means. The Medicare Advantage encounter data broadly is unique. I know of no other really comprehensive data. So in that sense, the data is unique, but it is publicly available with the DUA. But there are other types of data, like the bid data, which are not publicly available that MedPAC can access to. The MedPAC analysts have a lot of experience in dealing with all of that data. So they have a wide range of data, some of which is publicly available, some publicly available with DUA, some not publicly available, some collected by MedPAC. A lot of it's collected by CMS.
I remember signing the annual agreement to provide the bid data over. So
right, and they get it quicker. By the way, they get some of the data quicker. So than say the public would get.
Yes, I remember that too. So you mentioned the analysts. Tell us about the role of the analysts versus the staff. The analysts versus the commissioners. And the executive director, what those three components are of MedPAC, what they do.
Yes, I'll do that in a second, but I want to say something that for those at home that might not know a ton about MedPAC. So MedPAC's an independent congressional agency that advises Congress and to some extent CMS on Medicare policy. That's just what it is. It has an executive director. It was Jim Matthews. Now it's Paul Macy. When I was on the first time, it was Mark Miller who taught me everything that I know about it. And the executive director effectively manages the staff of analysts. So there's 20-ish analysts. There's other MedPAC staff that deal with like organizing the meetings and a bunch of other stuff. But it's a pretty small team in the grand scheme of all that's going on. And all of the sort of hiring decisions, HR decisions, all of that stuff is managed by the executive director. The executive director, I think on paper, well, maybe literally reports to the chair. So when I was chair, Paul or Jim would report to me. I, as chair, now it's Amal Navate, we're special government employees, part-time. It's not a full-time gig. So when you were at CMS, it was a full-time gig. For us, it's less. We maintain our day job. And then there's the actual commission, which is made up of the commissioner, 16 plus the chair. And the commissioners are chosen by the General Accounting Office, appointed by the General Accounting Office. They serve for 3-year terms. You can get 2 3-year terms. So I was on for 2 terms, that's 6 years. Then I was off for 6 years, then on for another 2 terms. And the commissioners are chosen to be expert in particular areas. Many of them come from industry. So we have people from the hospital sector, people from the nursing sector, physicians. There's an actuary, economists, some policy people. Those are the commissioners. And the sort of at the end of the day, the buck stops with the chair. So most of the questions about like who resolves any final disputes, if there's a final dispute, in many ways that would probably be the chair, although in cases that would have to be working through with the executive director, who has most day-to-day operational control over what goes on, what the staff does.
So that includes questions about methodology, or agendas, what to put on the agenda, how to go about a particular statistical analysis. That comes to the chair.
Well, it depends on the nature of who the chair is. So in my case, I spent a lot of time thinking about details of some of the statistical analyses. We hired, during my tenure, a research director, Karen Stokely, who's a PhD economist, to help with the methodological issues. And we report all the methodologies at the public meetings. And so commissioners are more than welcome to weigh in. They often do, say in some of our telehealth work, for example, you'll see that. And they certainly weigh in on issues related to, say, our Medicare Advantage analysis. But the ultimate decision at the end of the day would be made by the chair. But in case where the chair might not be an expert in methodology, the executive director would have a higher degree of influence in what that decision was. I think in my experiences, and that spans 12 years, the collaboration between the chair and the executive director was extensive. I can't think of an area where there was a significant disagreement between, say, Paul and I or Jim and I, and there had to be some overruling of do it this way, do it that way. I think there have certainly been healthy discussions about a range of methodological issues. But I don't think I can't recall a situation where there was a real fundamental disagreement that has to be resolved. At the end of the day, I think, like in a institutional sense, the chair would ultimately be the one that would make the call. But how a chair would implement that if the executive director is strenuously objective, honestly, I just have no clue. Luckily, that didn't come up in my case.
Who hires the executive director?
I think technically I hire the executive. I choose when the executive director. So Jim resigned, and we picked Paul, and so I think I don't even know what the word hired means in that context. I was involved in selecting Paul. Paul doesn't. I don't. The GAO or Congress or some entity hire. Actually, literally is Paul's contract is not with me. His contract is with the government. But the selection process is run through the chair. And I think if I was somehow upset with Paul, I technically could ask him to resign or some version of that. Paul's spectacular. Jim was wonderful. So I don't have a really good institutional sense of what would happen since it hasn't really come up. But basically, the chair is the one that ultimately is responsible for the running of things at the end of the day in the big picture. But because the chair isn't working full time, the executive director has a huge influence on both the day-to-day aspects of the analysis and on the day-to-day management of the staff.
And the agenda, how do the agenda get picked for the various reports?
So in my case, it was always collaborative between Paul and I. And so the question is really, what input do we take into when we choose that? So at the end of the day, our fundamental objective is to make sure we serve the Congress. There's a lot of connections, a lot of ways that the staff engages with Congress and staff. So there's some sense that you get that this is going to be an important issue. We talk to the commissioners. So the commissioners in my tenure could always reach out and say, hey, I want this on the agenda. I want that on the agenda. In April, in the meetings in the executive session, we have a formal session where we go around to each member of the commission and say, what do you want on the agenda for next year? And the staff is unbelievably diligent in recording that, going through the transcripts, knowing what's going on. And then there's things that I am interested. So, for example, I probably put, certainly early in my tenure, more weight on alternative payment models than other chairs might have. I was particularly interested in pushing MedPAC to think about payment for artificial intelligence or other types of software. So you've seen several reports that MedPAC did on software as a service and how to pay for that. But other areas, just to give some examples from my tenure, telehealth. Telehealth, I had the misfortune of being appointed in the middle of the COVID pandemic. I got appointed. My first retreat was June of 2020. July of 2020. And so we were remote for basically 2 years. And obviously, telehealth policy really took off. There was a ton of interest in Congress. And so that matters. In certain cases, Congress requests mandated reports. So Congress can tell us, do a report on unifying post-acute care payment or private equity. Data collection for ground ambulances is one that we've done. So Congress sets the agenda to the extent that they ask MedPAC to do things. And, we really, really, really want to be sure to make sure that Congress is getting what they're needed. So if they, we do all we can to oblige.
Tell me about the interaction between MedPAC and Congress and CMS.
So MedPAC does three things, largely. It does the March and June reports, which many people will be familiar with, and the discussion of the chapters in those reports happen in the public meeting. So most people have a pretty good idea of what we're going to do. The commissioners discuss all of those things. We have
and how much of MedPAC does is those meetings, because that's what the public really generally sees is those meetings or reads about.
I'm sorry, I missed the beginning of that question. I was still
how much of what MedPAC does is those meetings?
I'm not sure I can quantify it, but I certainly would say for the commissioners, that's 90% of it. For the staff, since I'm not there day to day, I wouldn't say, but the much less of the time is spent on the stuff for the public meeting. Maybe, I don't know, we should text Paul and see. 2/3, some version like that. They spend a ton of time on the comment letters. They're required to do the comment letters, by the way. And so they that's how they engage with the comment letters. The comment letters get reviewed by the chair and the vice chair. They happen very quickly. Well, they're very intense. I think the turnaround on them is very quickly. The staff spends a lot of time working on the comment letters. And then there's a lot of technical assistance between MedPAC staff and the Hill. And to be completely honest, as chair, I'm not involved in that for a bunch of reasons, institutional reasons. Most importantly, there's a level of confidentiality of folks within the government. The chair is a part-time employee. So I think it's important for there to be a space for the staff on the Hill and the staff at MedPAC to engage in technical support activities outside of the broad commissioner process. And they do that in a way that I had really no, I mean, I often know what was going on, but very little direct engagement in the technical support stuff. And the staff spends a lot of time doing that. And I think it's hard to appreciate without being involved how much work the staff is doing and how they're juggling the preparation for the public meetings and the comment letters when it's comment letter season and whatever requests are coming from the Hill. They are working very, very hard, a small number of people, to get a lot of material to Congress and out more broadly. So
you mentioned comment letters. You were talking about the comment letters on proposed CMS regs.
Go on.
It was remarkable that the commissioners didn't vote on those, but they voted on the other recommendations. Why is that?
So two things. A lot of it's just a timing process. The recommendations to get a vote on goes through, at a minimum, three sessions, generally more to get them through. And the comment letters have much less of a timeline, and the public meeting sessions are very, very tight. And the public meeting rules prevent us from having outside meetings or discussions on all of that. And of course, it's very hard to integrate the comments from 16 diverse people into sort of a voted upon comment letter. So I suppose anything's possible. But if I were chair, when I was chair, I would have, we talked a lot about how to deal with that, and it's just really hard logistically to make that work. I think the staff, when they do the comment letters, really, really, really works hard to make sure that the comment letters are consistent with sort of the bulk of the meeting discussions. And I will say, in my 18 years, 12 years on, it's spanning 18 years, my 12 years on, there's never been really a significant pushback on, oh, you said this, that's outside of the realm of where the bulk of commissioners were. There's always going to be commissioners that agree or disagree with particular points, but the bulk of the commission has never complained about a particular point in a comment letter, and I attribute the staff's attention and diligence. There's been situations where I've said in a comment letter, hey, we should say this, and the staff said, we can't say that because that's not, there hasn't been enough discussion in the commission on that point. Jim told me very early on in my tenure, and I think appropriately, that MedPAC's not Michael. And I think the commission staff takes that very seriously to make sure that the material that MedPAC puts out, including in this particular case, the comment letters, is consistent with the bulk of MedPAC documented discussion. And I think they do a great job at that. But to sort through a formal process on the comment letters and what we say, I think is not practical given the timing and the nature of the public meetings and public meeting rules and the diversity of opinions of folks.
Are they circulated internally to the commissioners and draft?
After the fact, and there's usually, by the time they get finalized, there's usually a day or two, and then they get circulated.
But the proposed draft reports obviously are, though, right?
Yes, because there's a ton of time. I mean, even then, just to be clear, some of the draft recommendations don't get circulated to the commissioners. They get released at the meeting because we have a meeting. The leadership has a meeting the day before the December meeting where we're going over what the preferred recommendations will be. So they're not really finalized. But certainly the chapters themselves get circulated to all the commissioners multiple times. They get the draft chapters. So we go through this very somewhat laborious but institutionalized process. They get multiple bites at the apple. And then the chapters also get reviewed by external reviewers. So there's a whole body. You may have been an external reviewer. I run into people periodically that will say, oh, I was an external reviewer on that chapter. So there's a lot of external reviewers from across the board, industry, academia, politically left, politically right, that review all of the chapters and make comments back to the staff. And as an aside, I don't get to review all of those comments, which is just as chair. It's not that I couldn't. It's just a timing thing. The time pressures, given the size of the staff and all the material that's being done, and the production pressures are such that not every edit gets reviewed all the time by, say, the chair, and nor should it, by the way.
You pull in other entities like OACT or CBO, OMB. Do they review or collaborate with you in other ways when you were at MedPAC?
Well, there's a lot of discussion. There's not. So MedPAC's an executive branch agency, so we report to Congress. Obviously, CMS is MedPAC's a legislative branch. CMS is an executive branch. They are separate. There are discussions at the staff level between CMS and MedPAC, CBO and MedPAC, when particular issues arise. If you want to take the CMS version that might be most relevant, the Medicare Advantage estimates. So there's been meetings between the CMS staff and the MedPAC staff on the way one estimates Medicare Advantage payments, for example. And there are other issues. Obviously, we're getting data from CMS, as you alluded to earlier. So there's connections about what's in those data, what's going on, how the data is working. There's often issues, institutional issues. How is CMS dealing with wage index issues that arise, or indirect practice expense issues? Where institutional data where there's just an institutional exchange of what's happening between the staffs. So they don't collaborate in the way that CMS does its work separately from the work that MedPAC does, but certainly at the staff level, I think there's a very good relationship between MedPAC, CMS, CBO, where when reasonable questions arise, the staff can communicate to make sure that everybody understands what's going on and how things are done. It's obviously important for MedPAC to know the way in which CMS is actually performing certain calculations. The treatment
Yeah,
part
it's
A
a
only varies.
small world, and the number of people who have the ability and opportunity to focus on these things entirely is small, and so the
Yeah.
universe definitely you know uh, run into each other, whether it's formal or not, or have opportunity to dialogue. So it's interesting to hear about that. What about other extra? And I was surprised. I think when I first found out about how large the MedPAC staff was, because it's a team that's fully devoted to an analytical function, and I know that would seem remarkable to someone coming from MedPAC, because I'm sure they feel like they have more work than they have people to do it.
Well,
But
they
it's
do have more work. They do have more work than they have people to do it. But in any case, go on.
But it's a tremendous resource to have a group of people sort of exclusively devoted to understanding the Medicare program and analyzing the data around it. I'm not even sure we have a sort of a separate group of that size in the executive branch when I was there. Uh, and that group has an opportunity to share resources and influence with both directly in terms of the report, but also in terms of other dialogues and conversation. Does MedPAC take meetings with external stakeholders around how they do their work?
All, including, as you know. So how did I know you met with MedPAC, what, like a week or two ago? How did you find it? I wasn't there. I wasn't chair at the time, but I know I helped, make that connection. So how did that go? I mean, you met with the MedPAC staff. How was it?
They're very open to hearing what we had to say when I was there
Yes.
with the group from Paragon.
They announce all the time. So they meet with, I don't know, dozens, hundreds, it seems like a gazillion external stakeholders from industry, from academia. There's an example where they were meeting with an MA plan. The MA plan came in with some analysis and actually influenced the way MedPAC does some of its calculations. So they spend a lot of time, and they, again, I really can't emphasize enough. The folks really want to, as staff, they really want to get it, quote, right. And they're very open to suggestions about do it this way, do it. That doesn't mean that everybody gets what they want, but they spend a ton of time meeting both to convey to people what they do. That probably is what happened in your case, but also to listen to people's ideas about what they think is important, what they think MedPAC might be missing. MedPAC does a lot. That is sort of just the, at the end of every meeting, I would say, if you want to reach out, please reach out. You can reach out to us at meeting MedPAC. Look, I forgot it already. Meeting comments at medpac.gov, some version of that email. Amal will say it at the September meeting. That will be the right way of saying it. But they also do a lot of focus groups. So MedPAC actively solicits inputs. So they go out and they meet with focus groups in the hospital industry. We're doing some work on insurance brokers. They meet with brokers.
Have you ever heard the proposal that MedPAC should put its chapters out or recommendations out for comment?
Well, they do. So we don't vote on any recommendation until there's been a draft recommendation, and so there's always at a minimum a month between the draft recommendation and the vote. So we never make a recommendation to vote without an opportunity for public comment. And usually there's a policy option. I don't know. Usually, I can't think of a time when there wasn't a policy option before there was a draft recommendation. And so there's usually several months between. Usually the policy options are discussed in, say, the September, October, November period. Not always. Then we do our updates in the December, January window, and then we come back to the draft recommendations and the votes if it's a June report thing. And that's all. There's always time to do that. And believe me, you hear from a lot of people about what the recommendations are going to be, what we're missing, what we're not missing. And so I think I actually think, and it would be interesting to say, CMS does its advance notices and then they do their final rules, right? And there's a formal process. So that's probably a little bit more formal than what MedPAC does. But I think in the grand scheme of like getting feedback compared to other agencies that are advisory, MedPAC is probably near the top in terms of soliciting feedback, listening to feedback. And I can say from personal experience, they take all of the feedback really seriously.
What would you the proposition that perhaps it would be helpful if MedPAC could put out its work at a level of detail that would allow outside researchers to replicate it?
Yeah, I think that like if you look at the Medicare Advantage work, I actually think they've done that. I think that's true with most of the work. And in fact, if there's ever a researcher, again, yourself included, or anyone else that has a question, hey, I'm trying to do X, Y, or Z, and I can't figure out whatever it is, MedPAC has been unbelievably open to supporting that. I think the challenge is um, it's a very big world we live in. And there's a lot of people that want to talk to the staff. This staff spend a ton of time trying to help folks do X, Y, or Z. And there's just limits as to how much time they can spend doing that. But I've been astounded, honestly, at how much time they do spend helping people understand, not just the public at large or researchers, but also say they've got, for example, in Medicare Advantage, describing to CMS what they've done. I can't think of an example where someone has said to me, you've done this. Why won't you tell me how you've done this? In fact, I think they do a way better job than most at explaining the math and the analytics behind what they've done. Now, as we said earlier, not everybody has the same data that MedPAC has, so not everything can be replicable because not everybody has the same data. But I think it's quite healthy. And as an aside, MedPAC also has become more involved in, as you know, there's a big academic community that addresses similar issues. Um, you know, Medicare selection. You have now Boris Vapson works with you all. He does a lot of Medicare Advantage work. And he's been part of the academic community doing that work for a long time. And now with Karen and the MedPAC staff, they present at academic conferences. They engage in criticism of their work, sort of the way academics would engage in criticism of their work. And so I think it's actually useful not just to have MedPAC doing it, but to have a broad, I mean, obviously I'm fundamentally an academic, so this may be a more egocentric comment, to have an academic community that is trying to address the similar issues. And I will say, if you take maybe the more controversial things like the Medicare Advantage selection or coding estimates, there's been a ton of attention to that. In fact, some of the methods are taken from academics, Rick Kroenig, although one could debate it. And in fact, the results are unbelievably consistent. And in the reports, MedPAC will talk about the sort of the lit review. This is what others have found. And this is what we find. Here's what the differences are.
Is there,
I think they do a great job of it.
is there an opportunity to also bring in then the operational and business reality check sometimes against some of those theories too?
I completely agree. Completely agree. Which is, yeah, I'm sorry, I didn't mean to interrupt you. And so let me just say, so when they have people on the commission, so if, like, for example, there are people who work day to day in the current vice chair, Greg Polson, for example, works for a big health system. And there's others. Wayne O'Reilly served with me. Robert Cherry is there. I'm going to be missing folks. I don't mean to. But there's a lot of folks that have that experience that are actually commissioners. That's why they're commissioners. But then there's also a series of focus groups that the MedPAC will do to try and do that kind of pressure testing on what would go on. And it's why it typically takes 2 years to get to a recommendation. From when you start with a topic to when you have some general discussions, there's usually an information gathering. They're doing work now on Medicare beneficiaries that reside in institutions. And so usually there's a big information gathering activity that involves not just what we would consider in academia like data, like official claims data, but also going out in the field and talking to folks. And then the second, if you're going to go further, there'll be a second cycle where you'll go through policy options, and then they will continue to talk to folks, and then a draft rec. They'll get comments. They'll invite comments from people on the outside if people think things are going wrong. And I will say there's a lot of letters we get from folks in industry, often from trade organizations, but even others that say, hey, it looks like you're going to do blank, and we just want to make sure you're aware of this. And it becomes a balancing thing that, and all those letters, as an aside, are made public so people can comment on whatever they are. I actually think there's more transparency than the world has capacity to digest. That's been my personal opinion.
That's a remarkable proposition. I don't know if I think there's always an opportunity for more, but regardless, I do think that it kind of points to one of the important challenges, I think, in Medicare policy, which is that Congress has specified so much of the program. In other areas, in some respects, in certain areas, they've left a lot to the agency's discretion. But it's definitely a program that is driven by a very relatively specific set of statutory programmatic mandates.
Absolutely.
And so this kind of attention and focus always on all of the granular aspects of what, in particular, the fee-for-service program does and how it operates. And that becomes the basis then, obviously, for everything else in Medicare. And does this kind of inherent aspect of how Medicare is currently structured, does it sort of drown out the opportunity for more market-driven or consumer-based approaches? And how can policy, wonks or others who are interested in policy, bring some balance to that?
Yeah, so there's sort of two aspects to your question, and I'd love your thoughts on this. So Medicare is an administrative program with a lot of administrative rules. You must have dealt with this all the time at your time at CMS. Many of them are statutory, but of course the statute gives a lot of leeway in certain cases for the statutes to be implemented in particular ways. And obviously you were instrumental in a lot of those things that Brian mentioned in the introduction of stuff that is how you run the program. The role of MedPAC, which might be narrower than your question, is really to help run the Medicare program as written. MedPAC is not IPAB. It's not a broad think tank like Paragon that's sitting around trying to say, hey, what if we got rid of the entire Medicare program as we know it and replaced it with something else? That's sort of a congressional thing. For other policy folks, you can engage in that broad debate. I think MedPAC's sweet spot is helping make the regulations as they exist better and suggesting ways in which the regulations and the laws themselves, the legislation, can be improved around the way the STARS program works in Medicare, for example, Medicare Advantage, or the update chapter, the update rules, the updates for Medicare fee schedules and stuff like that, as opposed to big, broad, hey, let's privatize Medicare or let's make it Medicare for all on those extremes. MedPAC, I think, is best to work on making the program as written work better and find what I would consider to be smaller places, necessary places where the rules could be done better as opposed to broadly reimagining the Medicare program. That's not, I think, a role that MedPAC would be great at now. Whatever the new chair or other people want to do, that's up to them. But my interpretation was always to sort of stay within the lane of what would help Congress and let them work through sort of really what I'll call revolutionary aspects of the Medicare program. In terms of market stuff, I think MedPAC, so there's certain cases, we had this conversation separately, things like bidding for durable medical equipment. Which is something, I think there's examples where MedPAC's been quite supportive of where market forces can work. Obviously, MedPAC has to make recommendations about update factors for the fee schedules, and that's a very narrow statutory thing that they're asked to do. But in terms of relying on market forces to set prices, there's a bunch of places where that type of thing comes up. MedPAC's been quite amenable to what those things are within the context. There was a whole chapter on competitive bidding in Medicare Advantage, just to give you an example. To be considered. So I do think there's, now outside of MedPAC, I do think there is a broad policy discussion to be had about the balance between the government and markets. My personal view is you're going to have a bit of both, and both are imperfect. And so you have to get the right balance. But in any case, I think there's a room for discussing what that right balance is. In the MedPAC case, it tends to be much more targeted about very specific issues. And really, it's around, as there's a ton of market failures in healthcare. So whatever you think about more market forces, it's sometimes said like, well, the market's got to be better. And that's just not true. The market can be better, but there's a lot of situations where the market is not working well in healthcare. At least I would assert that. We could have a discussion, and that in fact you need some level of government regulation to prevent abuses that otherwise might happen, particularly in healthcare where you need to maintain, for example, pooling. So you need some risk adjustment system or other types of ways of dealing with where there's too much market power or lack of information, all the classic market failures that people who study health economics would have been studying for, I used to say a half decade and a half century. Now it's more, right? Canero was writing the book in 63.
Most of that time has been a decidedly non-market based approach, though, at least with regards to Medicare.
Yeah,
I
I mean,
think.
Medicare in of itself, it's a government program. So Medicare in of itself is about how is about what to do. And you are right. If you look at basic things like, say, price setting, right? Medicare fee for service is an administrative price program. And MedPAC has a lot of discussions about the process by which those administrative prices are set.
And
But it's
people always ask me, is Medicare paying the right price for this? Is it paying too much or too little? How do you answer questions like that, either
so
when you were tech or now?
Yeah, so MedPAC in general, doesn't spend a lot of time on specific services and more on the process. So, for example, they've commented on the process by which relative physician fees are made. They've commented on the process by which data on, say, practice expenses are put into place. Um, they've commented on particular things like global surgical codes and where there seems to be a big gap between what's being paid and what we think the costs loosely are. Again, in a well-functioning market, you would end up with prices closer to cost. You don't always get that in an administrative system, and MedPAC makes associated recommendations. It's easy to say we should let markets work, but just to give you one example, if you look at the dialysis market, Medicare Advantage rates, so not market-based rates, they're 10, 13% higher in Medicare Advantage because you basically have no competition in the dialysis market, and you have and so market power plays out in a way that has higher prices. Now, there's a bunch of other stuff I don't want to. We can have a longer conversation about dialysis markets and what you're getting or not getting for the higher prices. But you would see the same in commercial markets where you don't have administrative setting. The commercial prices are, I don't know, 2 times, depending on what sector you're looking at, commercial prices. So you could argue, is that because Medicare is paying too low or commercial is paying too much? I think there's, in some cases, it's a little of both. But it's certainly not the case that if you got rid of administrative pricing, prices would now drop in the markets. That's certainly not what happens in the commercial market, right? Commercial prices are not obviously better.
Dialysis is a good example, perhaps, of the effect of government, because it's essentially government monopoly, due to the Medicare coverage rules. But I see your point that you're going to get distortion. You're going to get issues either way. I just, at the end of the day, you look at something like site neutrality and the differential that's paid, and it's perhaps, some would argue, a policy choice Congress has made or implicitly made, but it's an administrative price kind of result. And I'm curious what you think about that as an example, and maybe more generally about site neutrality.
Yeah. So first of all, the first thing in my mind is we need another hour, Demetrius, and maybe a beer. Maybe we should have a beer with everyone on the webinar to have this conversation. So let me say, I'm a big fan of site neutrality. MedPAC's been a supporter of site neutrality. I think there's an enormous numbers of nooks and crannies of Medicare payments policy that can be improved. And I think one of the real advantages of MedPAC is to both identify those and make suggestions about where pricing in an administrative pricing system could be improved. And there are a gazillion places, wage indices, like you could go on for the entire rest of our time on places where I think administrative pricing can be improved. And so it is easy to conclude that the government doesn't get prices right all the time. And there is no doubt that that is true. There's a lot of places that can be improved. I think the one thing I would say is, and I just think it's important, given the tone of your question, it is not the case that market always gets the prices right. And so if you look at the No Surprises Act and surprise billing and situations like that, there's a lot. So the markets aren't perfect, government's not perfect. There's some blend of how it plays out. And I think the question that you asked, I think, was a reasonable question. And I would say, as an economist, one way to interpret markets as an economist is they're information generating devices. They generate information. They let suppliers know what the demand is. They let consumers know what the costs of production are. If I was not an economist, I'd get that sentence right. But in any case, it is a reasonable question to ask how we can harness markets to get better and more fluid information as all these things are changing. But it is not the case that in a healthcare sector that markets don't have their own set of flaws and their own set of problems that needs some government reaction. And so site neutral is an example where I think, and MedPAC has said for a long time, we can make improvements in the way in which fees are set that would matter. I think there's other broader questions about just the nature of the fee schedules. Like, why is the fee schedule? Why do we have a fee schedule for outpatient that's different than the fee schedule for ASCs? And there's a bunch of reasons why we do. Why are the facility part for a physician paid for in the physician fee schedule if they're independent, but it's paid for the outpatient payment system if they're not, which is what gives rise to the site neutral problem. There's a lot of really micro
To how the
questions.
Macs did it in the early days, right? I mean, it's kind of that fundamental initial inertia is still carrying forward.
Absolutely. But I will say, like I've been a big advocate of alternative payment models. MedPAC's done some work that I think's been really good on alternative payment models, which try to at least mitigate the harms. I've written in other contexts that the problems with fee for service are really challenging. Like ignoring government or private sector situations, the problems with fee for service are really challenging given the nature of healthcare pricing. And so moving to a different pricing methodology like alternative payment models, which has its own set of problems, I think does have a lot of appeal for me. And I think certainly MedPAC has commented on that point, and that might help sort out the problem. So one of the issues we've been talking about, whether the prices are right, which is really a level issue, but understand that there's a separate question is the mechanism for pricing, fee for service, the way you want it to be, independent of what you set them at? Because you have all these unbelievably complicated nuances. Because remember, to get the prices right, you not only want to get the average price right, but the relative prices matter. That sort of Econ 101 is relative prices matter. And it's really hard to get relative prices right.
Look at how OPPS is structured, sort of fundamentally
Yeah,
around that.
completely agree. But there's challenges in however you do this. And there's certainly
Uh,
challenges if you remember the fee for service system grew up before actually to your point, the fee for service system that Medicare adopted in when it was formed was the system that existed prior to Medicare. It wasn't that Medicare came in and said, "Oh, we're paying alternative payment models, and now Medicare, no, everything's going to be fee for service." They just took the existing private sector payment approaches and moved the government into those payment approaches. It wasn't
yeah,
that the government set up fee for service.
but when you pour that amount of money and sort of percent of the market into a particular system that's then ossified around, by its nature, around government regulation and control, then it's going to have its own impact. And that's, I think, what the last, half century or much has shown us the impact of as well. Speaking of your work, written work, you've written a bunch about spillover effect. I wanted the time to pass without asking you why it is that MedPAC never sort of wrote a great chapter about the spillover effect. And
Yeah, as an aside, I have done work on spillover. I think MedPAC is acknowledged as a spillover. I think a lot of that, so we'll see what Amal does. A lot of it's a complicated topic analytically to get into. I will say as an aside, there's been a lot of discussion around the MedPAC estimates of the Medicare Advantage, traditional Medicare payment gaps, if you will. And I would say there's been a lot of criticism of that. I would say 80% of that, I have yet to hear a really valid critique of the work that MedPAC does. I've heard a lot of invalid critiques. I can tell you my favorite ones, which would be fun for me to say in a webinar. But in any case, I've heard a lot of what I consider disingenuous critiques. The one critique that I think actually is valuable, which I think MedPAC acknowledges, is the role that spillover plays, the role of Medicare Advantage, not just in the sort of static payment gap, but what would happen if Medicare Advantage expanded or contracted in sort of the comparison fee for service setting. And I do think that's an important topic. It is discussed, it is acknowledged and discussed by MedPAC. And I think finding the resources and the time and the ability to do that is something you'll need to have a mall on to discuss. But it was something that we've talked internally a lot about in MedPAC, and something that's very clear, and something that I actually think is probably the most important substantive under quantified substantive part of the Medicare Advantage fee for service debate. That's a personal opinion, by the way, but I think it's consistent with what sort of MedPAC's understanding. It's just not, they haven't yet gotten to the point where they can do the actual analytics. Luckily, if Paragon wants to do the analytics, or there's a lot of academics, myself included, that have done some of that analytics, I think that's a worthwhile debate to have. It's not easy to do. It's not straightforward for a bunch of sort of statistical reasons.
Speaking of things that aren't easy to do and the possibility of taking them on, what about the obligatory? I have the obligatory question about AI, but not how do we pay for AI? How will AI change the way that Medicare policy is analyzed, made, conducted? Things like understanding spillover is not necessarily that, but other things like it. Is AI going to change the way we understand and analyze and run the Medicare program?
So, yeah. So first, let me say, I think AI is particularly ill-suited for fee-for-service as a general point. But more broadly, I think the effects of AI will depend on the rules we put in place around AI. So I don't think there's an answer. This is what AI is going to do. Right? I think the answer is if we pay for AI in a fee-for-service way, the impact for AI will be different than if we incorporate it into alternative payment models. I think if we change the way AI models are regulated and approved, there will be a different ramification of AI, and if we don't, and actually I should add, right now I'm talking about clinical AI. There's a whole bunch of other AI stuff that's been really important, administrative AI that relates to how services are coded, for example. So if you look at the coding rates for sepsis or 99215, that's the more complex office.
Maybe we won't even need coding someday. AI can just we won't need codes. Just understand what happened in an encounter.
Yeah, so I'm not an AI researcher, so we could have a separate AI panel, but I will say the AI itself needs data. And so I think, for example, some people say, well, you should just apply AI to the medical record. But understand the medical record is not inherently truth. A lot of what's going on in the medical record depends on how the data in the medical record is being used in a bunch of ways. So I may be a bit of a Luddite in terms of my understanding of what the potential of AI will be in 2035, and this whole webinar won't age that well. But at least I think for the time being, we really need, so we started at MedPAC, and I think they will continue. We've really started thinking about what is the right regulatory framework to make sure that we get all the advantages of AI without opening the door to just tons higher payment and a lot of deleterious effects of having AI. And the AI also, how it's going to affect workforce is going to be unbelievably important. I do think the potential of AI will change what I would call the production function of healthcare, and we need to think about how we change our regulations, including but not limited to payment models, for those sort of production function changes. I certainly think it's easier in a Medicare Advantage world where you have sort of a broader umbrella to adopt or not adopt AI where it's helpful, but we have to get our Medicare Advantage regulations working well.
What's next for Mike Chernew?
Yeah, excuse me?
What's next for you?
Oh, what's next for me? So I'm doing a lot of work broadly in the areas of affordability. So some of that relates to how services as opposed to diseases are coded. Some of it relates to what types of care are driving up healthcare spending. Some of it related to AI payment. And then work on, how do we support hospitals? A lot of interest in the way in which we support hospitals. One of the most common questions why we get on the Hill is how do we support care in rural areas? And I will say, one of the things that I learned a lot about at MedPAC, I mean, I always knew rural was important, so I don't want to make it sound like I didn't, but it wasn't necessarily front and center of my thinking. And now I've spent a lot more time thinking about how do we pay in rural areas, or more broadly, how do we pay in areas where you're not going to have competition for a whole range of different reasons. And some of that involves how do we target government support. So there's just a lot of work on that, a lot of work on what comes after MACRA, a ton of work on the quality programs. I'm a big critic of the sort of existing quality programs, and so a lot of work on how to improve that.
All that sounds very intriguing, and I wanted to thank you again for taking this time and the audience for participating. It's been great to have an opportunity to dive deep on MedPAC's process and impact and some of the opportunities for reform. And I encourage people to visit paragoninstitute.org to subscribe to Paragon's newsletter and learn more about Paragon events and research like those that we've discussed today. And again, thank you to Mike for participating today.
And thank you. Thanks tons. And thanks for everybody for listening.